Okay, we're kind of waiting for our starting five to show up. Dr. Shakoor will be here shortly. Today's uveitis grand rounds will be on white dot syndromes, which is they're very interesting and often very confusing group of inflammatory chorioretinopathies. Just like a snowflake, if you look at them, they all seem the same, but you look at them, individually, they're actually heterogeneous, just like the white dot syndromes, a group of non-infectious uveitis that have overlapping clinical features that have multiple well-circumscribed yellow lesions at some point in time during their disease course, usually affecting the outer retina, RPE, choriocapillaris, and choroid. This is a list of what are commonly called the white dot syndromes. When I think of white dot syndromes, the first thing that comes to my mind is Birdshot retinal choroidopathy pictured here. Then I think you can group them into the placoid chorioretinopathies, which includes AMPI, serpiginous, relentless placoid, and then another entity called persistent placoid maculopathy. And some people think that these are a continuum of the same type of disease process. Similarly, for the multifocal choroidities, you have PIC, multifocal choroiditis, and panuveitis and progressive subretinal fibrosis panuveitis syndrome, which again is likely to be a continuum of this similar disease process, but is useful to divide them clinically because for treatment purposes. Then there are a group of other white dot syndromes, such as MEWDS, multiple evanescent white dot syndromes, acute retinal pigment epitheliitis, which I think only Deutman has ever seen, and Azor, acute blind spot syndrome, and acute macular neuroretinopathy, which are kind of grouped into a similar grouping, as they require different type of considerations for treatment. The differential diagnosis is extremely important because many other infectious chorioretinitis entities can produce white dots, such as syphilis, histo, tuberculosis, pneumocystis, candidiasis, and ARN in the beginning, and then non-infectious diseases such as sarcoidosis, sympathetic VKH, and most importantly, neoplastic masquerade syndrome such as lymphoma. The white dot syndromes have shared demographics. Usually they're younger people, myopic women, except for Birdshot, which usually occurs in middle-aged people, and serpiginous. There's a slight female predominance in many of these diseases. Their presentation is usually bilateral with the exception of MEWDS. Patients' complaints are to be taken very seriously. They present typically with photophobia, blurred vision, nyctalopia, floaters, visual field loss, and not infrequently blind spot enlargement, as do these symptoms when they recur. In about 25 to 50% of them, there may be a viral prodrome of these disease. And Gass was really the first person to think about grouping these into a complex of disease process with maybe a shared pathogenesis. We don't really know what causes the white dot syndromes. Don Gass posited a viral infectious etiology for Azor. I think many people believe that that infectious etiology may be partially responsible, but that they are autoinflammatory with common non-disease specific genetics, which may be triggered by some exogenous agents, such as a microbial or drug trigger. Whether or not they are a spectrum of a single disease or distinct entities really awaits an understanding of the pathogenesis of this disease. Interestingly, there is a fairly high prevalence of autoimmunity among patients with white dot syndromes and their first and second degree relatives. Overall, about 23%. This suggests that this increased systemic autoimmunity would suggest that there is some type of genetic, inherited, non-specific genetic predisposition to develop immune dysregulation in these disorders. So 23% as opposed to 4 to 5% in the general population. And the most common ones with this is self-reported autoimmunity are multifocal choroiditis, Azor, and Birdshot. The most common diseases that are associated are Hashimoto's thyroiditis, believe it or not, alopecia areata, and psoriasis. Each of these entities have variable lesion morphology and evolution, which will be described in some of the examples that are presented, with distinct natural histories and different visual prognoses and different disease-specific treatment indications, some of which requiring immunomodulation very early in the disease, and some of which may be observed. Multimodal imaging, such as color, IVFA and ICG, OCT and OCTA, and fluorescein and autofluorescence are essential in the evaluation and diagnosis of these. Here are a couple of examples. Oh, sorry about that. Of autofluorescence down the bottom at the border of a patient with serpiginous choroidal neovascular membrane. Sorry, guys. Choroidal neovascular membrane and OCTA of that membrane, and then little white dots, which are more visible in a wreath-like configuration and are visible on ICG in a patient with MEWDS. So they are important. Multimodal imaging is important diagnostically, particularly say, for example, in a patient with Birdshot retinal choroidopathy with a very blonde fundus in which ICG may show the lesions more specifically than you can see on examination. And then, of course, to indicate what are the structural complications that are responsible for decreased vision, listed here: optic nerve head inflammation, macular edema, retinal detachment, choroidal neovascular membranes. Then to assess the extent of the inflammation, one's threshold for treatment, and to monitor disease activity in response to treatment. So we're going to go ahead and present 4 hopefully quick cases that will illustrate some of these points.
Good. Thank you. I, for one, really don't like the phrase white dot syndrome, because it's I'm more of a splitter than a lumper. And when you look at just the diversity of this so-called white dot syndrome grouping, they're often not white, they're often not spots. So anyway, this is a patient who was referred back when I was 1 year into my faculty position, and she's a 20-year-old lady with sudden loss of vision in the right eye, along with left-sided numbness and paresthesias and a headache. And she was referred to the Moran Eye Center for AMPI. And just a few things that you can see, and these are the fundus photographs from the referring physician. But you can see that there's this area that's just kind of creamy and yellow. But then there's also these areas contiguous with this that seem a little bit more atrophic. So when we saw her in clinic, I don't know if these pictures, are they showing up? Is it, I think we should turn these lights down a little bit. I got it. You can see it. But you can see this creamy kind of area of retinal change right in the macula, right in the center of the fovea, and then you can see these areas of atrophy. But more importantly, also importantly, you can see these areas of retinal depigmentation, perhaps RPE atrophy out in the periphery in the left eye as well. The OCT showed loss of the outer retina in the very center here, limiting her vision to 20/80. But in addition to this, kind of the stippled hyperautofluorescence in the right eye, you can also see this lesion in the left eye, which in this eye, the patient was completely not asymptomatic. It wasn't bothered. So perhaps some of these lesions were a little bit older than this new lesion that brought her to our attention. The angiogram shows kind of this early blockage, this early hypofluorescence, followed by this late brush fire-like staining in the periphery of the lesion. These lesions here seem to just stain as if they're completely atrophic with loss of outer retina and RPE. This is the montage of the angiogram. I think we weren't using Optos as much back then, but you can see that there's these peripheral lesions as well that are atrophic. So, to the residents, does this look like AMPI? No, George, that's right. So we did some testing, all negative and normal for TB IGRA was normal, syphilis was IgG was unremarkable, CBC CMP were normal. So what would you think are your differential diagnoses? Start with George. Sorry, George. So is it AMPI? No.
Like TB, like a sort of like a microwave, or a sort of business choreography.
Yeah, certainly.
Pathogenesis,
Right. So it could very well be amphigenous or otherwise relentless placoid. But what about the neurological symptoms? Would you do anything more?
Yeah, so you want to get head imaging because there's an association with cerebral vasculitis.
Well, there isn't, or there wasn't, but so sure, we got head imaging, and you can see on the DWI this area of hyperintensity and hypointensity in the ADC images. And also, if because of this, they suspected cerebral vasculitis. So she got a cerebral angiogram, and you can see in the ACA circulation in the I think it's A2 and A5, and then in the M4 regions in the middle cerebral circulation, you can see this narrowing of the arteries, with also kind of this beating seen on angiography. So she was diagnosed with relentless placoid choreopathy with cerebral vasculitis, and she was given 3 days of IV solumetrol by neurology. She was transitioned to oral prednisone. I started her on mycophenolate, the highest possible dose, very quickly. On neurology's recommendations, we started rituximab infusions because that seems to be the standard of care for, was the standard of care for cerebral vasculitis at the time. And I injected intravitreal dexamethasone implant just to speed things along. 2 weeks later, her vision improves to 20/50, her outer retinal changes improve, she has no new lesions, her paresthesia is resolved, and she has now a normal MRI. So 6 months later, however, these lesions seem to be stable, but now she's got these 2 new lesions in the left eye, unfortunately, and this is often the course with relentless placoid. And this is unusual because she's on rituximab every 5 months, and her CD20, so basically her B cells, are 0 and have been for a while. So she's very immunosuppressed. She's on CellCept and a B cell inhibitor, and yet she continues to progress. So in consultation with rheumatology, we started her and this is just a little more peripheral. This is the spectralis wide field image at the 55-degree. And you can see lesions here, and then all of these new lesions here, 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 and here. So now she's starting to get symptomatic in her left eye. She's worried. We started her on infliximab at a rather high dose at 10 milligrams per kilogram every month, and continued to CellCept. Her lesion stabilized. There were no recurrences of her neurological symptoms, and now 8 years later, she's 20/40 in the right eye and still 20/15 in the left. She's now a qualified nurse. So these are the most recent pictures of her right eye. I saw her last week. She has stable atrophic lesions in her right macula that have not progressed for the last 4 years, and the left eye, just showing the extent of the disease, and how much more there is if you do autofluorescence imaging and if you look at the peripheral retina. So this is a challenging case of relentless placoid with cerebral vasculitis. This is actually the first such described case where we do have a cerebral angiogram in addition to an MRI. Steve Ye, in 2009, when he was at Emory, described one case where there were multifocal white matter lesions, but there was never a cerebral angiogram. He suspected this might be cerebral vasculitis. Cerebral vasculitis has been described in a condition that's often described to be similar to relentless placoid, which is AMPI. AMPI, however, conventionally tends not to scar, although there is outer retinal change, which is why I think Al, Marissa, and I all treat these AMPI patients with steroids, because you will lose something. And but never really described with relentless. So when patients complain of neurological symptoms, make sure you do the necessary. So, George. Oh, photographers, I collaborated with Bob Hesh and Shruti Sangvi for this case, and Eileen Huang, when she was a baby resident, put this into literature. Thanks.
I'm going to continue on the theme of more than you ever wanted to know about white dot syndromes. So this is a case of a 38-year-old woman presenting with gray spots in the left eye for 3 days. It was accompanied by intermittent flashes of light and some photopsias in the vision, or shimmering, as she described. She's a high myope, but otherwise healthy. She does have a strong family history of autoimmune disease. She's a physician and has limited travel and pet exposure. The exam was notable for decreased vision in the left eye at 20/50, otherwise an unremarkable anterior segment with just rare vitreous cells, but no haze in that left eye. Right fundus photo is unremarkable. And on the left fundus, we can see these indistinct yellowish white lesions scattered in the posterior pole. So differential at this point is a smorgasbord of white dot syndromes, as well as the typical suspects, sarcoid, syphilis, and TB. Autofluorescence shows some hyperautofluorescence emanating around the optic nerve. And on OCT, we can see some irregularity of the ellipsoid zone subfoveally, as well as nasally, where we saw the lesions on the exam. So at this point, I think certain white dot syndromes are getting higher on the list, as well as syphilis. An angiogram early on, maybe just very subtle hyperfluorescence in the peripapillary region. Later, that's a little bit more prominent. And if I zoom in on this area, maybe there's a little bit of like a halo of hypoautofluorescence around one of the hyperfluorescent spots. ICG early, there's a few hypofluorescent spots, and then later on, many more hypofluorescent lesions seen in the posterior pole than was appreciated both on exam and other imaging modalities. Our workup for the usual suspects was unremarkable. She was started on oral prednisone at 60 milligrams daily with a taper and had received Valtrex prior to our evaluation. And 2 weeks later, sorry, I'm gonna move this. So the autofluorescence does have a more dramatic appearance at this point, sort of more of those hyperautofluorescence extending into the macula. The ellipsoid zone is starting to normalize, but not completely normal. And so this is MEWDS, evanescent, meaning soon passing out of sight, memory, or existence. So MEWDS was first described in the 1980s by Lee Jampol. He saw it in 11 young adults with decreased vision and subtle white spots in their fundus, that their vision recovered without treatment within a few weeks. An infectious etiology is suggested by the prodromal flu-like symptoms experienced by some patients. Like Dr. Vitale mentioned, an exogenous agent may trigger an inflammatory response, as seen in many other white dot syndromes and disorders. And there's an increased prevalence of systemic autoimmune diseases in patients with white dot syndromes and their first-degree family members, suggesting some type of inherited immune dysregulation. An interesting side note, This study out of South Korea was reporting an increased incidence of MEWDS during the COVID pandemic. So out of all hospital visits, it went from 0.01% to 0.03% of hospital encounters. Of course, this is still very rare, but it was statistically significantly increased. And that's just pointing it again to some exogenous trigger, whether it be the actual viral transmission or the vaccination. If you happen to see the patient early during their course of disease, the fundus reveals these small 100 to 200 micron whitish yellow lesions with slightly indistinct borders concentrated in the parafoveal and foveal region. Foveal granularity is one of the distinguishing characteristics. You can have AC inflammation or mild vitritis, but if there's dense vitritis, think of something else. Certain retinal associated findings like splinter hemorrhages or venous sheathing has been described, but that's pretty rare. And while this is usually a unilateral and non-recurrent disease, there's at least 20 cases of bilateral reports in the literature, as well as at least 10 cases of chronicity or recurrence. And the natural course of the disease is self-limiting with recovery of the vision to normal levels within 4 to 8 weeks after onset, and regression of the lesions coincide with the visual recovery. So our patient probably didn't need that much prednisone. And if you remember, the autofluorescence 2 weeks after starting the treatment actually looked worse. And so we always have to pause and think, is our patient getting worse on steroids? But in reality, this was probably just the disease taking its natural course. It was still evolving. The imaging can evolve with it, sort of despite our interventions or treatment. So there's like a weird amount in the literature trying to describe what are the spots and dots that we see on exam corresponding to different types of imaging. So you can really get lost in it. But GAS classified lesions seen on FA and ICG as spots and dots, 2 components seen in some but not all cases. OCT imaging shows multifocal debris centered at and around the ellipsoid layer corresponding to the locations of the spots seen on photos, ICG and FA. A buzz phrase is this hyperreflective material resting on the RPE. And there can also be focal areas of decreased reflectivity of the photoreceptors and these protrusions of the hyperreflective material coming from the ellipsoid zone into the outer nuclear layer. In most cases, the RPE is intact, and this distinguishes it from multifocal choroiditis, which is also on the differential. In multifocal, we do have disruption of the Bruch's membrane and the RPE with an accumulation of that hyperreflective material under the RPE. There's different reports in the literature describing some hypoautofluorescence of the spots on autofluorescent photos, but I think this is the most classic appearance. All the ones I've seen of MEWDS looks like this, where it's only the hyperautofluorescence sort of speckled into the macula and surrounding region. Fluorescein angiography shows typical multifocal white spots to be hyperfluorescent in the early phases, and with some mild staining later on, and these groups of hyperfluorescent dots create this wreath-like pattern. That's kind of one of the buzzwords on the boards as well. On ICG, hypofluorescent lesions are seen in the posterior pole and extending into the periphery, often many more on ICG than we see on exam or other imaging modalities. And this suggests possibly some deep choroidal involvement, contributing to sort of previous thoughts that there was choriocapillaris injury in this disease, in addition to the photoreceptor abnormalities we see. But OCT angiography sort of paints a different picture. As this paper reports that all the patients studied with MEWDS in this had actually normal choriocapillaris and normal choroids. So that points away from choriocapillaris injury and implicates the outer retina and photoreceptors in the disease. So putting all the imaging together, this is an en-face OCT analysis comparing lesions seen on FA and ICG, showing that the dots are smaller in the outer nuclear layer and the larger spots are that disruption in the ellipsoid zone. As you can imagine, visual field testing will show a scotoma peripapillary or in the cecocentral area corresponding to what we see on exam. So a lot of these patients start in neuro-ophthalmology clinic and may have been grouped under ABC or acute idiopathic blind spot enlargement syndrome. I think a lot of patients said that we're told to have ABC could actually be this, either before we had the imaging to detect it, or in maybe community clinics that they're not doing all the imaging. And ABC is probably a term sort of a wastebasket term used to describe these entities that are poorly understood, like Azor and MEWDS, that do cause enlarged blind spots. Both full field and multifocal ERG can be abnormal in MEWDS in the early stages. We use multifocal ERGs to determine the functional topography of the retina. And while multifocal ERG evaluates the outer and middle retina, multifocal oscillatory potentials tell us about the inner retina. And when that's studied in MEWDS, it does suggest some inner retinal dysfunction that may precede the outer retinal dysfunction that shows up so well in the OCT. So our patient 6 weeks later returned to 20/20 vision. Her imaging normalized, autofluorescence is abnormal, the ellipsoid layer recovered. So I think of all the white dot syndromes, this would be the one that I would choose to have. It has good prognosis, really doesn't need treatment. Syphilis, also not bad, it's treatable, so you have to choose them. And that's all I have.
Hello, my name is Debora Lee. I'm one of the fellows. I'll be presenting a talk entitled The White Dot Sisters. So the white dot syndromes, there's many and they can be very confusing, but I'll cover two of them. Multifocal choroiditis with panuveitis and punctate inner choroidopathy. There are two conditions that are very similar, and by some, they're even considered the same disease. I find it helpful to remember them as the white dot sisters, and I'll go into a little more detail later. But briefly, I wanted to give an overview of both conditions, multifocal choroiditis with panuveitis and punctate inner choroiditis, are both idiopathic inflammatory multifocal chororetinopathies. They both tend to occur more frequently in young myopic women with no direct associated underlying systemic disease. They present with acute onset of yellow-grayish sub-RP lesions and later flatten out and turn into punched out atrophic chororetinal scars. They are considered idiopathic, but we must rule out infectious, inflammatory, or masquerade syndromes, which can present with a very similar appearance. The primary causes of vision loss in these two conditions include the development of those inflammatory lesions near the fovea, formation of a secondary CNVM, or associated intraocular inflammation in the cases of multifocal choroiditis. If there is vision-threatening disease, one may also consider starting treatment with systemic immunomodulatory therapy and/or anti-VEGF in the event that there is an active CNVM. So again, the two conditions are very similar, but I think there are some factors that may help us differentiate between the two. I like to think of multifocal as the older sister and PIC as the younger one, because multifocal patients typically are a little bit older. Their average age is around 40 years old, whereas PIC has an average age of 33. Both conditions have a female predominance and a high prevalence of myopia. PIC patients tend to be more myopic with a median spherical equivalent of minus 7.5 diopters. The inflammatory lesions in multifocal tend to be more peripheral, whereas in PIC tend to be more posterior. And because the multifocal is the older sister, their lesions tend to be a little larger with an average size of 380 microns versus 290 microns in PIC. Both conditions can develop CNVM, but it's more common in PIC patients. And importantly, intraocular inflammation is often present in multifocal choroiditis, but absent in PIC. Treatment is with systemic IMT is often used in multifocal choroiditis, and anti-VEGF is used if there is CNVM, which is often the case in PIC. So let's now go through a clinical case of each, starting with multifocal choroiditis. So this was a 60-year-old female with multifocal choroiditis who presents for routine 3-month follow-up. She had initially presented to us 3 years ago with peripheral chorioretinal spots in both eyes. Her workup for infectious inflammatory conditions were negative, and she was started on mycophenolate. She had remained stable and quiet for 3 years, and thus decision was made to taper off her mycophenolate. However, on follow-up, her vision had dropped. On the right eye, her vision was 20/25. There was half plus AC cell with new yellow grayish lesions inferior to the nerve. Left eye vision was now 20/40 with 2 plus AC cell, vitreous haze, and yellow grayish lesions in the macula. FA showed diffuse leakage in both eyes, confirming the presence of active intraocular inflammation in both eyes. Overall presentation was thought to be consistent with the recurrence or flare of her multifocal choroiditis. She was given Ozurdex in both eyes and restarted on mycophenolate. Follow-up several months later, her vision had returned to 20/20 in both eyes. There was no anterior or vitreous inflammation and resolution of her posterior inflammatory lesions. Now we'll move on to a case of PIC. So this is a 38-year-old female who presented with an acute onset central scotoma in her right eye starting in the morning. She had developed vision loss in her left eye about 5 years ago for unknown reasons. Her medical history was largely non-contributory, though she had high myopia in both eyes. She reports a possible history of valley fever and was previously lived in Central Valley, California. On exam, the right eye vision had dropped to 20/50. There was no anterior vitreous inflammation. In the back, there are active chorioretinal lesions. And OCT showed that these lesions were sub-RPE. And then adjacent to it, there was an active CN with associated intraretinal fluid. The left eye, the vision was stable at 2200. There was no anterior vitreous inflammation. There is an old CNVM with subretinal fibrosis and overlying cysts. Workup for syphilis, sarcoid, TB, and histo were sent and negative. She was given Avastin in the right eye for her new PIC-associated CNVM. And given that she was monocular and had a foveal-threatening lesion, a decision was made to pursue aggressive therapy and start methotrexate with an oral prednisone bridge. On follow-up, a few months later, her vision had returned to 20/20. The chorioretinal lesions appeared a bit more atrophic. And on OCT, we can see flattening of the sub-RP lesion and vast improvement of the CNVM and associated intraretinal fluid. So in conclusion, multifocal choroiditis with panuveitis and punctate inner choroidopathy are idiopathic inflammatory multifocal chororetinopathies. They often, but not always, occur in younger myopic women. They present with onset of yellow grayish inflammatory spots that eventually turn into atrophic punched out lesions. We always do, though, have to remember to rule out infectious inflammatory masquerade syndromes, and the disease course often involves the progression of new lesions, the formation of CNVM, and in the case of multifocal choroiditis, intraocular inflammation. The disease is visually significant. Patients may require treatment with systemic immunomodulation or anti-VEGF in the event there's a CNVM.
Good morning, everyone. My case is a little bit atypical of its spectrum, but let's look at it. A 39 years old white American man presented with painless blurry vision in his left eye. And as we see here in the initial presentation, the right eye color pictures was pretty much unremarkable, and the left eye showed disc edema without any hemorrhages and no vitreous haze. OCT was normal in both eyes, and fluorescein angiography at that time showed minimal disc staining inferiorly in the right eye, otherwise unremarkable, and the left eye showed optic disc leakage with leakage from the perivasculature, especially at the major arcade veins. Visual acuity was 20/20 in both eyes. AC was quiet. There was only 1 to 2 plus old vitreous cells in the left eye. Past ocular and medical history, as well as the review of the systems, were negative. And extensive workup, including infectious and non-infectious etiology, came back also negative of most of all the etiologies. And he was followed at that time without any treatment. And this time, 3 months later, he came back with the similar findings at this point also in the right eye, bilateral disc edema, OCT was still normal, and fluorescein angiography this time showed bilateral disc leakage with perivascular leakage. Overall, the patient had retinal vasculitis and optic disc inflammation in both eyes. Visual acuity was slightly decreased to 20/25 in the left eye, and he was noted to have 2+ vitreous cells at that point without any haze. An additional workup also conducted, including ENCA, anti-dsDNA, anti-CCP coagulopathy panel, which were all negative. And at that point, he was started on oral prednisone 60 mg daily with tapering. Over the course, the clinical findings improved significantly, and fluorescein angiography also showed improved leakage significantly. Visual acuity was 20/20. Unfortunately, 6 months later, he came back with the recurrence of similar findings with bilateral disc edema and disc leakage, as well as the perivascular leakage, and this time also angiographic macular leakage in both eyes. Visual acuity decreased to 20/25 in both eyes, 1+ vitreous cells without any haze in both eyes. AC was still quiet. Given the chronic course and the refractory nature of the disease, he was at that point started on mycophenolate as an immunomodulatory therapy for the long-term control of the inflammation with a prednisone bridge treatment. Over the course, he improved, his inflammation improved, and 9 months later, for the first time ever, it was noted that he had these creamy-colored ovoid lesions, especially in the nasal retina in both eyes. OCT was still normal, visual acuity was normal, and fluorescein angiography showed a similar pattern of leakage in both eyes. At that point, ICG was also performed, showing numerous hypofluorescent lesions in both eyes. And it is an additional testing. He, at that point, had HLA-A29, which came back positive. With all these findings, he was diagnosed with Birdshot chorioretinopathy. As an additional testing, he also had full-field ERG showing attenuated scotopic values more in the left eye than in the right. And cyclosporin was added to his treatment regimen. And visual field, Goldman visual field also showed enlarged blind spots in both eyes with peripheral scotoma in the right eye. And if you look at the Birdshot chorioretinopathy, aside from our case, actually, it's most commonly seen in white women at their 4th to 5th decade, typically in modern European descent. And these patients typically have post-equatorial cream-colored ovoid lesions, which are smaller than the disc diameter at the choroid and RP level, mostly bilateral and symmetric, but it can be also asymmetrically present. Mostly in the nasal retina, it starts, and it has a radial distribution from the optic nerve. And it may not be seen at the initial presentation, like in our case, and typically those lesions do not get pigmented over time. The highest HLA disease association in the medicine so far is HLA-A29, which has a very high sensitivity and specificity for this disease. But the important thing to remember here is it should be only used as a confirmatory test because 7% of the healthy population also have HLA-A29 positivity. Patients usually present with blurry vision, nyctalopia, disturbed color vision, sparkling, flickering lights, all may indicate this subtle disease activity. And initially, these patients have usually preserved visual acuity. AC is usually quiet. There's only mild vitritis, mostly without any snowballs or snow banking. And these patients typically have retinal vasculitis, disc inflammation, and cystoid macular edema. And CME is actually the most common structural complication in this entity. 84% of these patients develop CME in their 5 years of disease course. And there's no systemic disease association in these patients. Course is usually chronic with multiple recurrences and remissions, and we discuss about the multimodal imaging findings. Important thing to remember is to monitor these patients also in functional aspect with full field ERG and Goldman visual field. And early initiation of IMT is highly crucial in these patients. Traditionally, these patients were treated with conventional IMT with 2-drug therapy, such as antimetabolites plus calcineurin inhibitors. But recently, with the biologic era, TNF-alpha inhibitors are also quite effective in the control of the inflammation. And monitoring, as we discussed, should include both full-field ERG, Goldman visual field, as well as FA and ICG. Of course, it's important to remember to rule out the sarcoidosis and lymphoma in these patients. Going back to our patient, he had been doing fine without any significant inflammation, significantly improved fluorescein angiography. Visual acuity was 20/20. ERG was stable. He had been treated with this two-drug therapy with stable Goldman visual field. And over the course, given the stable and the actually remission of the inflammation after 2-3 years of treatment, he was gradually tapered off IMT. And unfortunately, a few months later, he came back with the recurrence of these similar findings, with the more prominent in the right eye than in the left, and he had to be restarted on mycophenolate. And he also, over the course, developed persistence of the inflammation and develops additional scotomas on the Goldman visual field. Therefore, adalimumab was planned to be added to treatment with the dexamethasone implant in both eyes as a bridge therapy. Also in the literature, Birdshot patients reported to have potential late recurrences, and therefore at least 30 months of successful treatment is ideally recommended for these patients. Another report comparing resistant versus responsive cases indicated that the more affected Goldman visual field, the presence of disc leakage, vessel leakage, and macular leakage at the initial presentation shows more resistant course in these patients. Another report from Messianier showed that this similar pattern of leakage as in our case may be an early manifestation of Birdshot disease, and actually a significant majority of the patients with uveitis and this FA pattern will likely develop Birdshot chorioretinopathy with positive predictive value of 82.2%. Another report also similarly showed bilateral retinal vasculitis in the initial presentation in all patients. However, 24% of their patients did not have these typical Birdshot lesions at the initial presentation. Another report also from our center indicated another presenting feature as a disc edema can be in diagnostic, not diagnostic, but like suggestive for Birdshot disease, if especially there is vitritis, chorioretinal inflammation, and retinal vasculitis. So in conclusion, Birdshot is a chronic progressive disease with strong association with HLA-A29. Early initiation of IMT is crucial. Monitoring should include FA, ICG plus functional tests, including a full field ERG and Goldman visual field. And as in our patient, prior to typical fundus lesions, these patients may actually present with retinal vasculitis, disc edema, and cystoid macular edema. Thank you very much for your attention.